Sir, I'm starting with the session now. Greetings and a warm welcome to all the dignitaries present here. I'm Shwasika from Team Clearnet, serving as your designated session assistant to ensure a smooth and seamless experience throughout the event. Clearnet proudly stands as India's most trusted digital platform, offering a wide range of enriching services exclusively for the doctors. It is indeed an honor for us to serve as a digital partner for this esteemed event. The central focus of today's session is recent CPCR guidelines. Now, I would like to invite Dr.AL.Meenakshi Sundaram sir, a distinguished anesthesiologist and academic leader. Sir has served as a dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of Indian Society of Anesthesiologists and has held key positions including governing council member, president and state secretary of the ISA Tamil Nadu state branch. So without any much further delay, sir, I would like to hand over the session to you. Kindly proceed, sir. Over to you.
Thank you, Clinton, for the opening remarks. I welcome all the delegates for this 49th webinar. And this 49th webinar, the youngest faculty is going to be Abinaya Ramalingam. So Dr. Abinaya has done her MBBS in Thuthukudi Medical College, Government Medical College, Thuthukudi. And she is now doing her MD post-graduation in anesthesiology in Indira Gandhi Medical College, Puducherry, under the leadership of Dr. Pratibha. So she's going to talk about automated external defibrillators. And she's interested in painting. Her hobby is painting. But painting means, I don't know whether it is whitewashing of the house or artistic painting. So I think she may be good at both. So her spouse is employed in government hospital, and he is a physician. So I welcome her for this webinar. And as postgraduate participation is compulsory, we have included Dr. Abinaya Ramalingam. But at this time, this is the second time it is happening. The great stalwarts are participating in the webinar. Usually, we encourage the emerging leaders in anesthesiology. But the first time, I have recruited the high-end faculty for medico-legal session. At that time, all the three were stalwarts, except that postgraduate. She is going to be the would-be stalwart. Same way, Dr. Abinaya Ramalingam should realize that she is sharing the dais with the top leaders in anesthesiology. So Dr. Baljit Singh is going to talk about that basic cardiac life support, and he is a professor emeritus. He is a professor emeritus, and he was the former professor and head SGT Medical College, Gurugram, Haryana. And he is interested in patient safety. That is the reason why he is going to talk on CPCR. And Sir is the past national vice president of Indian Society of Anesthesiologists, high-end academic person. He is a scientific director, Indian Resuscitation Council Federation, IRCF. So he is a member BLS task force. That is the reason why he is talking on basic cardiac life support. He is in the International Alliance Committee on Resuscitation. We call it as ILCAR very commonly. And he is a president designate and a CEO, Indian College of Anesthesiologists. He is a member, Indian Medical Advisory Council, and consultant medical programs regarding Smile Train. And he has a mammoth figure of 174 publications to his credit. That speaks volume and volumes of Dr. Baljit Singh. And more than that, he will be a very, very good friend to everyone. And he is a good human being with humble character. Whenever you meet him in Delhi, definitely the dinner will be sponsored by him, compulsory. So he used to take everyone. He enjoys it by that Mehman कहते हैं हम. So he is known for his good hospitality. And I wish him all the very best. And I am very happy that I know Dr. Baljit Singh, and it will be followed by Dr. Rakesh Garg. Dr. Rakesh Garg is a professor in All India Institute of Medical Sciences, New Delhi, which is still the prestigious unit, even though AIMS have started everywhere. AIMS New Delhi has a special reputation, and he is a professor over there, and he is in charge of onco anesthesia. And more than that, he was very popular. He was the editor in chief of Indian Journal of Anesthesiology. So he has made a tremendous progress in the editorial board, and that even for index, PubMed index, he has done a great work. And he has 350 publications to his credit. So he's both national and international journals he has published. And just because he has published 350 papers, it is quite natural that he is the right candidate for editor in chief. And he has done his job commendably well. From 22 to 25, he was the editor in chief. And more than that, he has authored 25 chapters in the books. And he has edited two books. So his areas of interest will be onco anesthesia, airway research, and cancer pain. So that is the reason why he is in onco anesthesia. And when these two stalwarts are there, we have to have a greatest person possible for moderation. So we have no other person except Dr. Chakra Rao, so that he can stand above the shoulders of these two people. He is such a great man. First of all, Sir is a additional director of medical services, retired. So he is in public health with anesthesiology qualification. He was in public health, so that is something great. So he was retired, and he was the former secretary of Indian Society of Anesthesiology. And he is a former president of Indian Society of Anesthesiology. He was the national president, and he is a member ambassador group of WFSA, that is World Federation. And he is advisory board member for Indian Journal of Resuscitation. And he has received Dr. A.P. Singhal's Lifetime Achievement Award in 2021. And again, he has received Dr. A.K. Sinha National Award. He has received IMA Distinguished Services Award. He was appointed as Indian representative for ILCA. That is how he is standing as a icon in IRCF. Even his background, you can see his background is IRCF. His mind is preoccupied with IRCF. If you ask him to talk on any subject by omitting four letters IRCF, he will keep mum. He will never talk. Whenever he talks to anyone, automatically that IRCF will come. And every time he will give a work for everybody to concentrate on that CPCR. He has popularized the life hands only life support, that is COLS, compression only life support, Cole's program he has popularized, and throughout India, because of his perseverance, everyone followed, and that has earned a credit for him, and he has become a ILCAR member. And previously he was a tutor in anesthesiology, everything he has covered, and he had a lot of membership like critical care medicine and anesthesiology, as he is a past president, and All India Difficult Airway Association, everything. So he was awarded a gold medal by Governor of AP, and he has received felicitations from former Vice President of India, Dr. Venkaiah Naidu. So he is a good scholar, and even with all these qualifications, he is a good friend. He is a good friend. Probably his wordings may be little bit. I can say that it will be having that tone, that decibel may be more, but he is just like a jackfruit. So if you ignore the thorns which are seen outside, then interiorly he is a good human being, sweetest to the core. So the correct terminology for him will be, he is a jackfruit in anesthesiology. So I love this jackfruit because we are not bothered about thorn because we will be having much more thorns than that jackfruit. So I love to have him here. And incidentally, our 48th webinar, this is 49th webinar. So the 48th webinar had such a volume of attendance actually. So it was attended by 1009 people. It was physics in anesthesiology. So 1009 people attended that program. So that is another credit because previously for non-operating room anesthesia, 1009 people attended. So the 48th webinar was physics for anesthesiologist. So the physics for anesthesiologist program was a much successful one, and people from Karnataka participated in that. So this program also, I expect lot of attendance for this program because IRCF is going to be a wonderful program, and the faculties are very strong. All these faculty with the junior most Dr. Abinaya. Last time it was Dr. Varshini, a postgraduate from Bangalore Medical College. She has delivered a lecture on humidifiers, followed by Dr. Smita KS. She was a assistant professor from Bangalore Medical College and she has discussed about gas loss in anesthesiology. And Dr. Rashmi D. Souza, he was discussing about pressure and fluid dynamics, and it was moderated by Dr. Vinay Marula Sidappa. He is a FRCA graduate and done the moderation wonderfully well. And naturally, live 1009 people participated. So the Puthukkottai Bhudhan webinar crossed 1000 figure thrice out of these 49. First is for Boyle's machine. It was 12th webinar, and 42nd webinar anesthesia outside the operating room. Previously, it was 1003, and for operating NORA, it was 1009. And again, for physics, it is 1009. Tomorrow, we will come out with the figures of the attendance for this IRCF. And with this, I hand over the session to Dr. Chakra Rao, moderator. Please, sir.
Good evening. Thank you, Dr. Meenakshi Sundaram, the former Director of Medical Education, Tamil Nadu. It is a real pleasure for us to participate in this very good, nicely organized webinar. And really, you have been conducting it for the last 48 weeks regularly without any issues, and the topics are very much interested, and it is gathering a good number of people. Actually, regarding the CPR, the Indian Resuscitation Council is formed with the associations of the Indian Academy of Pediatrics, Indian Medical Association, Indian Society of Anesthesiologists, Indian Society of Obstetrics, Indian Society of Critical Care Medicine, the Trained Nurses Association, and the 108 or the EMRI. So all these together we have formed, and in 2023, the ILCAR has recognized us as good potential persons, and they have given us a membership. Till that time, there is no membership for India in the ILCAR, even though we are 1.45 billion population. And actually ILCAR consists of organizations like American Heart Association, Heart and Lung Resuscitation Society of Canada, the European Resuscitation Council, the South African Resuscitation Council, the Australia and New Zealand Resuscitation Council, and the Asian Resuscitation Council, comprising of Singapore, Thailand, Japan, Taiwan. And there is no uh, role for either India or China, which are the most populous countries. We have represented that we are actually the ILCAR is omitting the most populous countries and making the guidelines. And finally, they have realized not only that, we are doing a very good work on the World Restart a Hard Day. World Restart a Hard Day was declared on 16th of October with the World Anesthesia Day. And we are doing wonderful trainings every year, more than even in the first year, more than 2 lakhs, and rising every year. They have realized that India should be on the uh, registration ILCON, and they have given us a place. Not only given us a place, there are 7 members from India who are the task force members, Dr. Rakesh Garg, Dr.Baljit Singh, Dr. Alok Samandre, Dr. Lokesh Tiwari, Dr. Arun Bansal, Dr. Ver Raghavan, and Dr. Nepalkar. So all these people, not only we are representing a lot of good number of people from the Indian continent, but all these people have the persons who have contributed for the writing of the new guidelines. So the 2025 guidelines are released in Rotterdam on 22nd of October, and actually it is a new leaf for the resuscitation guidelines. Actually, the resuscitation guidelines will be uh, revised every 5 years, and these are all the stalwarts. Dr. Baljit and Rakesh are among them, and other people I told you. And now Rakesh is representing. Previously, he was in ACLS. Now he is uh, taking care of the artificial intelligence in the um, ILCAR groups. So this is all about India and ILCAR. And now it is for you to um, say or release it to the public through your platform about the recent guidelines. Thank you very much.
Sir, you can request Dr. Abinaya to talk.
Abinaya, please present your.
Yes. Good evening, everyone. I'm truly honored to present in front of you expertise, and I'm truly grateful for this opportunity. Thank you, sir. Myself, Abhinaya, doing post-graduation in Department of Anesthesiology in Indira Gandhi Medical College and Research Institute. Today, my topic is about automated external defibrillator. And my objectives are introduction, how actually defibrillator works, type and waveforms, AED, criteria to apply AED, principles for early defibrillation, electrodes, and universal steps for usage of AED and special circumstances. Introduction. Sudden cardiac arrest refers to sudden cessation of cardiac activity with hemodynamic collapse. The most common reason behind the sudden cardiac arrest are ventricular fibrillation and pulseless ventricular tachycardia.
Dr. Abinaya, please go for slideshow mode. Slideshow mode. Fine. Yeah, share your screen in slideshow mode.
share your screen. There will be a cup-like thing on the right bottom. You click it. This one.
Dr. Abinaya, it's visible. You have to go for slideshow mode. Yeah. Fine, carry on.
You are muted, Dr. Abinaya. You are muted. Kindly unmute yourself.
Yes, sir. The sudden cardiac arrest refers to sudden cessation of cardiac activity with hemodynamic collapse. The most common reason behind sudden cardiac arrest are ventricular fibrillation and pulseless ventricular tachycardia. Although several interventions can improve the likelihood of VF resuscitation, the single most effective intervention will be electrical defibrillation. This effectiveness is time dependent. So the time to defibrillate is the most important to for the success from the sudden cardiac arrest. So collectively, early access and easy applicability of the AED will increase the success rate for the survival from the sudden cardiac arrest. With this note, so how actually defibrillator works? It actually produces nearly sustained and simultaneous depolarization of the myocardial mass. So it will produce momentary cessation of all ectopic arrhythmogenic activity. So the viable site within heart's intrinsic conduction system will initiate the electrical impulse, which can restore the normal propagation of electrical activity, will produce successful ventricular contraction and thereby pulse produce. So this is how the defibrillation will revert the ventricular fibrillation or pulseless ventricular tachycardia to normal sinus rhythm. So the indications for defibrillation are shockable rhythms, that is ventricular fibrillation and pulseless ventricular tachycardia. Contraindications are, there are no absolute contraindication if provided the shockable rhythms are present. Coming to the waveforms, if the energy and the electric current is too high, there might be damage to the myocardial cells also. If the energy is too low, we can't even revert the ventricular fibrillation. So the modern AEDs have designed in such a way to provide effective lowest possible energy to revert the ventricular fibrillation. And these waveforms are divided into two types. One is monophasic and other is biphasic. As the name indicates, monophasic sends electric current in only one direction and it provides energy of about 200 to 360 joules. In biphasic, the conduction of electric current will be in two phases. The electric current will flows in one direction and reverse and flows in opposite direction too. And the energy consumption here is 120 to 200 joules. As we can see, there was less energy consumption and less damage to other tissue with biphasic forms compared to the monophasic forms. These waveforms are further divided into truncated exponential waveforms and damped sinusoidal waveforms. The rate at which the energy decreases to zero can be divided into these two types. That is truncated exponential and damped sinusoidal. If the rate of current decreases to zero very gradually, it is known as damped sinusoidal. If it is decreased to zero very exponentially, it is known as truncated exponential. Nowadays, AEDs have incorporated biphasic truncated exponential waveforms. AED, it is sophisticated computerized device that are reliable and simple to operate, enabling lay rescuers with minimal training to administer this life-saving intervention. With the inclusion of AED use as a BLS skill, BLS now encompasses this AED in the first three link of chain of survival. It can analyze the rhythm, recognize the rhythm, advise the operator whether the rhythm should be shocked or not, and it's very easy to use. It is available everywhere. It is available in housing boards, cafes, casinos, and airplanes, airports, and railway station. It is also available in healthcare providing systems also. So where to apply AED? If the individual does not respond to shouting or shaking their shoulders, if the individual is not breathing or not breathing effectively, and the carotid pulse cannot be detected. Why we are so worried about early defibrillation, because the most frequent initial rhythm witnessed in sudden cardiac arrest are ventricular fibrillation. And the most effective treatment for ventricular fibrillation is electrical defibrillation. Ventricular fibrillation tends to convert into asystole within few minutes, and it can't be reversed by the defibrillation because it will be non-shockable rhythm. The CPR during VF helps in only preservation of brain heart function. However, it is unlikely to convert VF to normal rhythm, which can be done by defibrillator. Earlier the defibrillator, better the prognosis. Coming to the electrodes, which is also known as adhesive pads or pads, it allows sensing the signals and delivering energy to the patient. The standard adult electrode size is 8 cross 13 centimeter, and pediatric pads are also available for pediatric age group peoples. Larger the pad, lower will be the resistance. And the positions where can be the pads can be attached to the patient, or anterolateral position, anterior-posterior position, anterior left infrascapular position, anterior and right infrascapular, and biaxillary. And the types of electrode pads are internal pedals and external adhesive pads. Coming to the universal steps of AED, first step, we have to power on the AED. This initiates voice prompts which guide the operator through the subsequent steps. And second step, we have to attach the electrode pads on the upper right sternal border, lateral to the left nipple, with top margin of this electrode pad 7 centimeter from the axilla. Some models will attach the electrode pad to the AED through the cable. In some AED model, we have to attach the electrode pad to the AED through the cables and all. We have to make sure that the pads are effectively attached to the bare chest of the patient. After that, the AED will analyze the rhythm. When the AED prompts you clear the victim during analysis, we have to during the analysis period, we have to make sure that no one is touching the patient to prevent the errors during the analyzing period. The analysis period will take up to 5 to 15 seconds and will vary according to the models also. After that, step 4, delivery of shock. The AED then prompts you if the shock is needed. Look to be sure that no one is in contact with the patient, and loudly state clear the patient message and press the shock button. The shock will produce sudden contraction of the patient muscle, and then you can resume your CPR. So quick brush up of these 5 steps. First, we have to turn on the AED and attach the pads. Third step is to analyze the heart rhythm. Fourth step is to deliver the shock. Fifth is to resume our CPR. Special consideration: if the patient have hairy chest, the patient we have to firmly press the pad against the bare chest of the patient. Even though the AED prompts you to check pads or check electrodes, you have to quickly pull off the electrodes so that it can easily remove the hair from the chest. We have to make sure one more electrode pad is there before doing the step also. Still, the AED prompts you to check the pads or check electrodes. Sometimes the razor blades will be available in the AED kits itself. We have to shave the hair before attaching the electrode pads. Same goes with clothes and jewelry also. One thing we have to make sure is effective attachment of the electrode to the bare chest of the patient, because this will reduce the impedance. Then water, as we all know, water is the good conductor of electricity, and it may possess the risk for both the rescuer and the patient. So it is critical to quickly remove the victim from freestanding water and dry the victim before attaching the electrodes. For children, if less than 8 kg, initial priority is to maintain airway oxygenation and ventilation. If shockable rhythm present, the pediatric pads will be available in the AED kits itself. We can use the pediatric pad, or else if you are going to use the adult pad, switch on the pediatric mode in the AED. If pediatric mode is not available, if the pediatric pad is not also available, we can set the energy to 2 to 4 joules per kg. If there is any transdermal medical patches, it may cause burn injury to the patient. So make sure to remove and wipe the area clean before pad attachment. For implanted pacemaker and ICD, place the pad at least 1 inch away from the implanted device and follow the usual step. Sometimes, if ICD is delivering the shock to patient, allow 30 to 60 seconds for ICD to complete the treatment cycle and analyze the rhythm, and we can use the AED. In pregnancy is not a contraindication to use AED. The only difficulty for pregnant patient is the engorged breast. We have to make sure the adhesive pads are firmly attached to the patient's chest. So here in the first image, the anterolateral placement of the pad we can see. In children, they have placed anterolateral and anteroposterior placement of electrode pads are also available. So this is the summary of what we have seen now. And other features, this AED has the ability to continuously record the arrest rhythm ECG, and it derives measure for CPR performance and record the voice of rescuers in the event and real-time feedback guide to CPR. And the challenges in the AEDs are, it requires the presence of bystander to apply and operate. Only 50% of cardiac arrest are witnessed. After some time, this VF will progress to asystole, which cannot be revertible by the defibrillator. So this is one of the challenges, and it requires interruption in the CPR, and cost of AED can be important obstacle. Thank you, sir.
Dr. Abinaya, you can stop sharing your slides.
Yeah.
Yes, sir.
Nowadays, actually, we are calling a bystander as a lay rescuer. This is actually approved in the recent guidelines. Okay.
Sir, do we go ahead, or is there anything else to be said? Do
So,
am I audible?
yeah, you're audible, sir.
Yeah.
So, moving forward, we'll have next session, which is related to the updated guidelines with regards to the cardiopulmonary resuscitation, which has been recently considered by ILCOR, and they have been accommodated into guidelines by various professional bodies. And this session is taken by Dr. Baljit Singh. Over to you, sir.
Thank you so much, Dr. Rakesh. Good evening, and first of all, I would like to thank Dr. Meenakshi Sundaram for very generous introduction, and it's always a pleasure to share the platform with Dr. Chakra Rao, who's the chairman of Indian Resuscitation Council Federation and a very close friend, Dr. Rakesh Garg as well. Okay, there is some problem with this. Rakesh, what do I do?
This is moving off its own, sir.
Yeah.
You can just stop it and open the slide again and then do it, sir.
Okay, I'll stop it and let me
close the slides also, sir, and reopen, sir.
Do I do it now?
Yes, sir.
It's still happening the same way.
Can you send to me, sir? I will share from my side, sir. Or if it is okay, sir, can I take my session and then you can come along? Or You can share with me. I can share from my end also, sir.
Okay, as you like. There's no issue with me here.
మళ్ళీ ఒక చిన్న చేత్తో రాసి పంపించాను, చూడండి. అది కిందది మాత్రం మామూలుగానే ఉంటది. ఎక్కడెక్కడ తర్వాత శ్రీ అబ్దుల్ నజీర్ అని పెట్టాను. అది మరి సాహిబ్ కదా శ్రీ ఒప్పుకుంటాడో లేదో అంటే అందుకే ఆయన పంపించేస్తే రఘువన్నోడికి వాడి కరెక్షన్ ఫైనలైజ్ చేసిన తర్వాత చెప్తాడు. మిగతా మాత్రం కింద మాత్రం మిగతా మామూలుగా వచ్చేస్తాం.
Rakesh, I'm trying once more.
Yes, sir.
It doesn't work out. It worked quite well. It's happening the same way. Rakesh, I think you can please go ahead with yours. I'll meanwhile send my presentation to you.
Sure, sir.
I'm sorry for this.
No, sure, sir. I'll start, sir. Meanwhile, you can just check it.
Please go ahead.
Sir, is my slides clear, sir?
Yes, sir.
Yeah.
Yeah.
So thank you so much. So we'll start with the advanced and comprehensive cardiopulmonary resuscitation. Thank you, Abinaya, which has nicely elaborated upon the use of electrical therapy, the defibrillation, the various concepts. Let me take you through some of the recent things which has been released by International Liaison Committee on Resuscitation. This will be equally good for clinicians, but also for postgraduate students who are listening to us. This may be an exam question, maybe asked in Viva Voce, but simultaneously it remains important for us to give best evidence-based CPR to our patients in case if they have unfortunate event of cardiac arrest. Now, the most important thing that has happened in the year 2025 by the ILCOR, that they have trying to shift the philosophy from an algorithm-centric CPR. Algorithm-centric CPR means the stepwise approach that was being considered for resuscitating a patient. Yes, the stepwise approach still remains, but they're also considering the environment in which this whole event is happening. So they are being shifted to something called system-centric, equity-driven, and quality-focused. So each step that we have on those algorithms, it is a system which runs and provides the best quality and which is at times individualized to a patient care. And this is the important aspect which we need to understand. Simultaneously, it's equally important. It's not just the algorithm, but we need to have a leadership for training and rollout of these programs for teaching the quality care, or we can say the quality teaching as well. And when we say quality teaching, quality delivery, and quality conduct, somebody has to audit. And sometimes, as a couple of years back, Indian Resuscitation Council Federation emerged that we need to have the guidelines which are suitable to us. Even in a single country, sometimes it will be a ecosystem where our guidelines needs to be fitted into that ecosystem. So it has to have a contextual adaptation. And sometimes when there is a resource limited conditions which can happen in any country, whether we talk about the tertiary care centers, countries there, or we are talking about small centers, peripheral centers, where we label them as resource variable settings or resource limited settings. We need to have that flexibility of the contextual adaptation to the guidelines. And that's why we need to understand these guidelines very clearly. When we say system generated, the other word which ILCOR has incorporated, we want to resuscitate a patient who has some pathology. When we want to resuscitate it, we need to ensure that the stepwise approach is followed. So this means the compliance of the algorithm or algorithm compliance must be there because there has been having some evidence behind it. But simultaneously, it also has to be a physiology and system-driven resuscitation. So when we discuss a little further on, we will realize that when we say we need to look for the underlying cause for the cardiac arrest, we need to intervene, we need to consider various interventions that can reverse the reversible causes for which this patient has undergone cardiac arrest. That is what we need to say. We have to move. The ILCOR also suggests algorithm compliance and moving towards the physiology and system-driven resuscitation. This may be a short note at times for the postgraduate students also in their exam. Now, what is changed in this year by ILCOR and even other resuscitation council, including the American Heart Association, the European Resuscitation Council, which has released their guidelines in the last ILCOR face-to-face meeting. CPR is no longer viewed as rigid sequence of steps. And the emphasis is on physiological targets. When we say quality, quality means we have to target something, and those targets are physiological targets like end-tidal carbon dioxide, the system readiness, and the outcome-oriented care. And why this change was brought? Because the high-quality CPR, early defibrillation, and coordinated systems contribute more to the survival. So it's just not the algorithm, but the other things is equally important if you want to increase our return to spontaneous circulation in patients of cardiac arrest. Also, it has been seen in evidence that registry data consistently show that the process quality we mean the compression fraction, time to shock, team performance. When this is ensured, the outcome is good. The persons who have returned to spontaneous circulation with least neurological deficit is much better than when we talk of an individual interventions, say as simple as cardiac compression. Now let's see some of the recent updates, ILCOR, which was adopted by the other resuscitation councils, and many of them are already a part of the IRCF guidelines, and probably in near future we will come up with more readiness, which is in sync with the philosophy of ILCOR also. Now, chain of survival. Now, basically, chain of survival means a certain integrated steps or philosophy which is important for good survival. Now, both the American Heart Association as well as the European Resuscitation Council has also put emphasis, which IRCF also agrees, is on the prevention aspect. Prevention means when these patients are in the hospital, they are high-risk patients. We need to monitor them and pick them early before they goes into cardiac arrest. For example, a patient who is admitted into a nephrology ward with chronic renal disease and having a borderline hypotassium, they may go into hyperkalemic cardiac arrest. And these patients require prevention. This patient requires prevention by vigorous monitoring, by taking care of the electrolyte imbalances these patients have. The techniques, interventions during the management remain similar, that we want to do a early CPR, early defibrillation, immediate care. But we also need to emphasize on the survivorship. And we also need to consider the low resource setting. And this low resource setting is not only for the poor countries. It can be at any place, even for a country which is in a high income cadre. They also can have a low resource settings, specifically when a cardiac arrest happens in the periphery or in a remote area where the immediate care by a tertiary care center may not be feasible. So this is what we need to understand. And this is in sync with almost all resuscitation councils, that now we also need to put prevention or preventive strategy for a patient who are prone for cardiac arrest before they goes into cardiac arrest. And if they have into cardiac arrest, whether we talk about AHA, we talk about ERC or IRCF, though the terminology may be a little different, but we talk about recognition and early activation, we talk about high quality CPR, we talk about early defibrillation, and we also talk about advanced care, which may be from the point of assessment and intervention in the form of airway, breathing, circulation, and other reverse the reversible causes. And then we talk about the recovery and the survivorship. Now, having said that, Dr. Chakra Rao also mentioning the same aspect about the community response. We understand that the patient who sustains cardiac arrest, almost more than 80 to 85% of these population will be outside the hospital when they have an unfortunate event of cardiac arrest. And when they have cardiac arrest outside the hospital, the immediate help from the lay rescuers or lay responders will be the only option. And hence, we need to encourage that community response, not only of good quality, but also of immediate response. And this is what has been highlighted by all the resuscitation councils who are member of the ILCOR. Whether we talk about ERC or AHA, which has recently released the guidelines, they have talked about the responder activation. And this is also we need to our Indian context also, that the calls program, which is ongoing, is working in the same situation, that whenever it happens, those are available, and within seconds or maybe a minute, they can start resuscitating these patients, at least with compression only life support, so that at least they do not have an hypoxic brain injury. Now, having said that, the introduction of telephone CPR or guidance, these are the emerging things. And I'm sure that these are emerging from Indian subcontinent also. So we can always start working on those aspects. And when we talk about putting these patients on CPR by layperson, yes, they are finally supported by the emergency medical services, because we want to move them to the hospital, nearest hospital at the earliest. So EMS activation is one of the option, and the first responder starting CPR after this assessment, wherever the patient is, whatever the situation is, and they can be really guided. And this is what the things are taking it forward by all the societies. Another important aspect that also we need to look for is the cardiac arrest center. Cardiac arrest center means the facility wherein the initial care can be given to these patients, especially the non-traumatic. We have trauma centers, but this is for non-traumatic. They can be taken care of and provide them absolute protocolized care so that the outcome becomes good. The extracorporeal CPR, this may be a short note for the postgraduate students also. Now, this is an emerging technique when we talk about the use of advanced system. This is again emerging where it can be used as a rescue therapy for some type of patients who are refractory to the initial management or a conventional CPR, and still you think the chances of patient recovery could be there because patient is well preserved. The CPR was started at the earliest. There probably is no chances of hypoxic brain injury. There, what comes about the extracorporeal CPR, which is again advanced technique at a tertiary care center. And then once we integrate all those things, all these societies, IRCF, ERC, AHA, they have been talking about teams, which is primarily the lay responders, lay rescuers, to work on them. And then as we have been doing, the India is also emerging in the same area of the provision of availability of AED at the public places. I'm sure that the early defibrillation will also emerge as one of the good intervention in improving the ROSC in patient population who has a cardiac arrest. And this dispatcher assisted or telecom assisted CPR, I think all the guidelines, the ILCOR is also supporting them. And I'm sure this is again another upcoming things that the IRCA will be looking for starting such type of facilities on a bigger platform, though it is happening at many places in localized area, but we need to look for on a pan-India basis so that we can help them up. Now, this is an important topic, and this again is important for postgraduate students also, but clinicians simultaneously, the ethics guidelines. Now, when we do CPR, everybody of you must have heard the recent 2023 Supreme Court guidelines, which has talked about the ethics involved into patients who are suffering from chronic disease. Now, this ethical principle has been well considered by ILCOR also, and they have been talking about certain things which are like shared decision making, equitable healthcare, termination of resuscitation, patient participation, and organ donation. And the government of India has also been keenly involved into these type of area in India also. So it becomes more important that those ILCOR initiatives are very well applicable, though Indian people, the government is also working on the same line already for last 2, 3, 4 years. So I'm saying it's well suited that India has already taken this initiative when we talk about all those aspects of ethics. Now, when we talk about ethics, there are certain things which we need to understand. One, we have to support in patients in understanding and share their values and preferences. As we have recently have advanced care planning by Supreme Court of India. So this means the patients who are suffering from chronic disease, they are having terminal illness, we should provide them whatever they want if they have some decision making as a part of advanced care planning. And that's why we need to support the population, we need to understand their the social structure, and that's why we need to provide them. Also, simultaneously, we also need to think of the bystander and the first responder support system, which we can always give. And then, as I usually say, that we need to get more data from our country so that whatever the guidelines are, they are more suitable. And this, the research ethics, where and how we can do it, also needs to be followed. And then we need to educate ourselves, and simultaneously also need to consider, even though sometimes we have started CPR, when to terminate. There are various concerns. Simultaneously, some endpoint needs to be considered when to terminate resuscitation. This needs to be individualized, but the inclusion of advanced care planning and terminal illness, when we talk about palliative care, should also be considered in these patients by the healthcare professionals. Now, this is what the inclusion, when I was talking about system in the beginning as endorsed by ILCOR, we are talking by various people that comes into the system: healthcare professionals, patient and families, bystanders or lay rescuers, researchers, educators, and trainers. And this is what is required for following ethical principles of CPR training and its delivery so that the patient gets benefited. The shared decision making is equally important. We need to understand the patient condition, understand by assessing them appropriately, outline the available options, think for what are the patient goals, values, and preferences, and accordingly choose a strategy for these patients and discuss with them. If patient is not the right person to be discussed because of its present situation, at least the patient, the family members, the immediate caregiver should also be a part of this shared decision making. As I mentioned, advanced care planning is important. Being in the advocacy by Supreme Court, the advanced care planning is becoming important, and hence we should be looking for it when we either not to initiate CPR or to terminate resuscitation as per the scenario is. So we need to have a team-based decision based on a holistic approach before considering termination, patient's values and preferences, look for prognostic factors, the reversible causes, and look for the other aspects that in a planned manner we can think of that how this can be carried out. And this is well settled in India. I'm sure that this will be taken further on. The patient preferences is again important, especially when we talk about emergency research. Inclusion into the process becomes very important, and educating public for both the aspects remains important. Now, looking some of the important updates with regards to the pediatric ALS, which has been considered. The chain of survival is common among most of the resuscitation councils. But what they have emphasized is that we need to look for the skilled providers who can provide them a sufficient airway support, because many of them would have air-related issues for cardiac arrest rather than cardiac, which happens in the patient. The emphasis on early adrenaline and rapid defibrillation is also advocately strongly for pediatric population. The CPR quality, again, we need to ensure and maintain a diastolic blood pressure of more than 25 for infants and more than 30 for children. Now, the important change that has happened in these ILCOR in 2025 was related to the targeted temperature management. I think targeted temperature management requires a lot of infrastructural requirements, and it needs to be have a controlled environment. So what these guidelines have changed it, rather than saying a targeted temperature management, the emphasis has been to avoid hyperthermia, avoid fever in these patients, which could be reactive, which could be infective. So this is what has been a major change that has happened in the ILCOR suggestions with regards to evidence update in 2025, and obviously maintaining the hemoperfusion. Now, a couple of things I will bring you. This may come as exam notes also, that what are the changes. The use of the vasopressors. Now, there have been certain drugs which has been preferred here. The most commonly drugs are the epinephrine and the vasopressin. Epinephrine remains the drug of choice for non-shockable rhythms, but the focus is shifting from which drug to when the drug is given. So this means the timing becomes important, and the judicious timing for shockable rhythms after initial defibrillatory attempts is the right time. At the earliest, the epinephrine should be given in these patients. So if it is non-shockable rhythms, give at the earliest. If it is shockable rhythms, at least initially after 1 or 2 defibrillation attempts, you should start giving them vasopressors, and the epinephrine remains the drug of choice. And it has been well supported by various studies. The airway management in CPR. Now, the airway management is important because you have to deliver certain oxygen. And some of these patients who sustain cardiac arrest may have an hypermetabolic state sometimes, and hence it becomes important to give them an optimal ventilation using an airway gadget without interrupting chest compression. So there's not much emphasis on the definitive airway using endotracheal tube, but other gadgets can also be used, and there are recent updates which are coming up of the use of the HFNC also for these things. There is nothing specific which is the best device, but hypoventilation and hyperventilation both should be taken care of. There is no mandate for early intubation. Stepwise airway escalation is preferred. And when this escalation is being done, the main basic principle is that the chest compression should not be interrupted. And this has been emphasized again in this, because there have been multiple trials which show no survival advantage of earlier tracheal intubation over supraglottic devices. So that's why the supraglottic airway devices has been emphasized much more in this group of evidence update, and as well as the guidelines, which becomes important. Capnography. When we say the quality of chest compression, there are certain physiological monitors, and capnography has been considered, it has been reinforced as a standard of care during advanced life support. For basic, sometimes it can be outside hospitals acceptable, but for advanced, definitely capnography has been advocated, because it not only confirms tube placement, but is equally important for the quality assessment of CPR. And whenever there is an early ROSC, this capnography, the sudden increase in the end-tidal carbon dioxide indicates the return of spontaneous circulations. Because when we say capnography, it very well correlates with cardiac output, with the cardiac function, and hence that's why it has been used not only for quality assurance, but also for the recovery of these patients when they are being treated. Oxygen titration. Another important aspect which has come into ILCOR evidence update in 2025. Avoidance of routine 100% oxygen after RFC. We have to target normoxia, not hyperoxia. So once a patient has return of spontaneous circulation, we need to wean the oxygen also and use it as a drug so that we are happy with 95-96% saturation for these patients, so that they are being avoided giving excess oxygen. Because of hyperoxia, definitely we understand hypoxia will lead to injuries, but hyperoxia will also lead to formation of free radicals, the oxidative injuries, and they have been found to worsen the neurological outcomes. And hence, we also need to look for brain-directed resuscitation. So in very earlier days, we understand that it is not cardiac and pulmonary resuscitation, but we also have to target certain organs, and brain and kidney remains the one of them. We have discussed in the initial session about the defibrillation strategies. I will summarize what the recent update has happened in 2025. Now, yes, we have to give early defibrillation. Standard techniques remain the same. Escalation needs to be done. But what additional things has come up is there was some evidence of double sequential defibrillation, which should be used as rescue strategy for patients who are not responding to the conventional drugs and conventional defibrillation. These patients can require double sequential defibrillation. And the ILCOR evidence and the guidelines has emphasis on the correct pad placement and uninterrupted CPR. So again, they are coming to the same aspect. Now, this is what the pad placement is. You need to have the right path, and there are two aspects of it. One is the vector change, and second is the dual or the double sequential external defibrillation. Vector change means you will place them the different directions, and double sequential external defibrillation is that you will be give two shocks in a sequence, in a rapid sequence, using two vectors. This means you will require two defibrillators for these patients. One will be in anterior lateral position, as you can see in the picture, and one will be in an anterior posterior position. So sometimes those who are refractory patients not responding to conventional defibrillation, they may respond to higher energies given in succession. And this is usually for the persistent refractory ventricular fibrillation and has been found to be of use in these population. Vector change means you change the position of the pads from anterolateral to anteroposterior. Because it has been seen that anterior posterior, the axis of the heart, the electrical transmission happens to those, and the arrhythmia is taken care of. But when it's changed into anterior posterior, there will be a greater LV myocardial mass, and probably it improves the transmyocardial current flow, and thus it can take care of the arrhythmias that are happening. So usually when again it is for when the conventional technique fails for 3 to 4 standard shocks, you can use them. I mentioned about therapeutic hypothermia. The hypothermia is one of the protective mechanisms which were mentioned. But what has changed is that the shift from mandatory hypothermia is to strict fever prevention, because the higher temperature is a condition, a situation which worsens the neurological outcome as compared to the other techniques. So emphasis on prevention of fever in these patients, which could be reactive or infective, and hence needs to be taken care of. There are certain gaps which are still being worked up, which is the best vasopressure combination, what are the best options for refractive ventricular fibrillation, how artificial intelligence can be incorporated to provide good CPR, what needs to be done for CPR in frail and palliative population. Though there are some suggestions, but we need more research into these areas that will be of help. So to summarize, 2025 CPR updates from ILCOR and various resuscitation councils are more based on the physiological optimization. They are more on system-centric, that is the ecosystem, and they are more focused on continuous competence and training. And they are more based on community ownership, so that a package can be given to these patients so that they survive better. Many of these are already a part of the CPR guidelines, and they will be coming up very soon for some updates into these guidelines, though they are minor, but they will be refurbished with these changes in a very near future. So thank you so much, and we'll proceed with the next session about the basic cardiopulmonary life support. What recent updates are there? Over to Dr. Baljit, sir.
Yeah, thank you so much, Dr. Rakesh. Wonderful lecture. It's always a pleasure listening to you. Whatever be the topic, you make it so simple and so clear and so nicely you present that it goes straight to every word, straight goes to the heart. Okay, let me try once more in case I can succeed in sharing the slides now, and if they don't bother me. No. I think, Rakesh, you will have to come in.
Sure, sir. So can you stop sharing, sir?
I'll do that. There I am.
Sir.
Thank you once again, Dr. Kesh and Dr. Meenakshi Sundaram for this opportunity to share the platform with you. Can we go to the next slide, please?
So same issues happening, I think.
What's wrong with it?
So we'll start from here, sir.
Okay. ILCOR, as has already been said by Dr. Chakra Rao, and Dr. Rakesh also mentioned about this. ILCOR is having 6 different task forces. One is basic life support, the advanced life support, which Dr. Rakesh has already covered very well. Pediatric life support, neonate life support, then the education, implementation, and teams. That's another committee task force that they have. And the last one is the first aid. Now, this is, these modifications which we have is based on the key points from recommendations which are considered the most impactful in the last 5 years. These guidelines, as you are all aware, these are changed every 5 years. Whatever research has happened anywhere in the world, wherever it is published, whichever journal it is published, whichever language it is published, all those studies are looked at, and for each and every change which the ILCOR committees go through, it's a lot of work because thousands of studies are reviewed to pick up the best points or pick up the most important points which can be incorporated in these guidelines. Now, what is new here in this resuscitation? Now, if an adult is non-responsive or unconscious with absent or abnormal breathing or the gasping that we may call it as, the lay rescuer should assume the person to be in state of cardiac arrest. This is a class 1 and a strong recommendation, level C. And this recommendation is derived from expert opinion, case studies, and standard of care. If an adult is unconscious or unresponsive with absent or abnormal breathing, the healthcare worker should check for pulse for not more than 10 seconds. And if there is no pulse, it should be assumed that the victim is in a state of cardiac arrest. He should immediately call for emergency medical service, assess breathing while he waits for the call to be answered. The assessment of the breathing will be at this particular time when he is making a call. If he is alone and there is no phone, well, it's hypothetical. Almost everybody has phones with himself. But in case the phone is not there and he's alone, or there is no network, which is more likely a possibility in some situations, shout for help and assess for breathing. Now, if you think that no one will come, you are in such a remote area, you don't see anyone around, leave the person to alert the local emergency service and do this as quickly as possible because local emergency service has to be activated anyway. The risk of commencing CPR in an unresponsive individual who is not breathing normally but not in cardiac arrest is far outweighed by the increased mortality associated with delayed CPR in those who are in cardiac arrest. So the benefits of starting CPR is much more than not starting the CPR. Recognizing cardiac arrest after a seizure when the person remains unresponsive with abnormal breathing is important to prevent delayed CPR. The risk of delaying CPR in cardiac arrest far outweighs any risk from performing CPR on a person who is not in cardiac arrest. Athletes who suffer cardiac arrest may continue breathing more regularly and have their eyes open following the collapse. Next slide, please. About the BLS sequence, CAB versus ABC in adult BLS. A compression first approach is strongly recommended for adult cardiac arrest in adults in cardiac arrest. Switching from ABC to CAB increases bystander response. It improves key elements in resuscitation, the time to first compression, and it's easy to learn and retain because uniformly it is followed that way. The error possibility is much less, and it stops wastage of time to bring interface for rescue or rescue breath or ventilation. Next, please. Yeah. About the pediatric life support, a new good practice statement suggests that either a compression first or ventilation first approach for starting CPR in children is reasonable, both ways. Now, we know that in children, the possibility of cardiac arrest is more likely to because of a respiratory event as compared to the adults where it's more likely to be a cardiac event. A prior recommendation to begin CPR unless a pulse is palpated within 10 seconds was replaced with a new good practice statement that rescuers should start CPR for any unresponsive child who is not breathing and doesn't have signs of life without relying on palpation of the pulse, because palpating the pulse in a child, if it's a chubby child, it's sometimes difficult and that may waste a lot of time, may mislead also. Next. Here. Now, CAB and versus ABC in pediatric BLS, both CAB and ABC approaches are acceptable. That's good practice statement. But there is a stronger recommendation for rescue breath in children. Hypovolemia and shock are as common as hypoxia for bradycardia in pediatrics. And AHA states that conventional CPR, that is chest compression with breaths and ventilations, should be provided to infants and children in cardiac arrest. That's level 1 evidence. And the European Resuscitation Council states that if the person is not pediatric basic life support trained, 5 rescue breaths to be delivered and CPR in a ratio of 30:2 compression should be started. If the rescuer is pediatric basic life support trained, 5 rescue breaths and then CPR in the ratio of 15:2 is to be done. Next, please. What is new in resuscitation with regard to pediatric compression? A prior recommendation to begin CPR unless a pulse is palpated within 10 seconds, as I mentioned earlier, is now replaced with the good practice statement that rescuers should start CPR for any unresponsive child who is not breathing and does not have any signs of life without relying on palpation of pulse. And in unresponsive children, not breathing normally, and without signs of life, lay rescuers and healthcare professionals should begin CPR. Next, please. What about the technique of the pediatric resuscitation? Use the 2-thumb encircling method for chest compression in infants. The earlier technique of using two fingers, not two thumbs, using two fingers to do the chest compression has been removed now. It's a two thumbs encircling method for a small child. Use the one hand or two hand technique in children older than 1 year. Just one hand with the heel of the hand, or whenever unable to give high quality chest compression with the two thumb encircling technique. Up to 1 year child, two thumb encircling technique, as you can see in the upper picture there, right upper picture. That's the technique. But in case the person finds after some time with use of two thumb encircling technique he cannot do it, then he can use the one hand technique. ILCOR supports two thumb encircling technique with evidence claiming better compression depths and less rescue fatigue. Next, please. This I have already said. Elimination of two finger compression in infants. Systematic review and meta-analysis from simulation studies suggests that the two thumb encircling hand technique is a superior technique when compared to two finger compression, particularly for depth. In a multi-center prospective observational registry study, the one-hand technique resulted in greater compression depth than two thumbs technique in infants, with no difference in chest compression rate between the hand positions. Next, please. If there is a foreign body airway obstruction, improved clearance of foreign body with the use of back blows over abdominal thrust has been recommended. So to create consistency for instructional purposes and in the absence of inferiority from pediatric data, management of severe foreign body airway obstruction in children now starts with cycles that alternate 5 back blows followed by series of 5 abdominal thrusts to be repeated as necessary. Next. Earlier it was, in adults it was just abdominal thrust, and now it is that in adults also you have to give 5 back blows and then go on to abdominal thrust. Next, please. We can skip this. Next, please. Positioning and location for CPR. The effectiveness of chest compression delivery can be improved through optimizing rescue hand position, rescue body position, and the patient position. Whenever possible, CPR should be performed on a firm surface. If it is outside the hospital, it is more likely to be on the patient is likely to be on the ground, as if you find him in the park, in the roadside, or in a shopping mall or somewhere, unless the patient has had cardiac arrest on the bed at home or somewhere. A rescuer should position themselves so that the knee is aligned with the patient's torso, either by kneeling next to the patient in case the patient is lying on the ground, or using a stool for improved chest compression quality. During the COVID-19 pandemic, the use of prone position for patients with hypoxic respiratory failure led to increased experience with the use of prone CPR. While the spine position is preferred, rescuers can consider providing CPR in the prone position if the spine position is not possible or would lead to significant delays in initiation of compressions. Next slide, please. Based on additional studies, the use of real-time feedback devices during CPR is recommended to improve manual CPR performance. Studies comparing mechanical to manual CPR have shown that mechanical CPR devices are no better than manual CPR in improving patient survival. The routine use of mechanical CPR devices is not recommended. There is no benefit, but may be considered in specific situations in which high quality CPR cannot be maintained, or for healthcare professional safety, such as while the patient is being transported from the site of event to the hospital, because there providing CPR may be difficult, because as the vehicle turns, the possibility of the healthcare worker kind of turning this side or that side is a possibility, and he may not be able to do the chest compressions as well. Next, please. Compression ventilation ratio. Earlier in 2020, it was that the EMS providers perform CPR with 30:2 ratio or continuous chest compression with positive pressure ventilation delivered without pausing chest compressions until a definite airway has been placed. Dr. Rakesh has already covered it, and the present recommendation is that EMS personnel use either a 30 to 2 chest compression and ventilation ratio or chest compression CPR with positive pressure ventilation at the rate of 10 compressions, 10 respirations per minute, delivered without pausing compressions. That's a strong recommendation. It's without pausing compressions to ensure that the chest compression fraction is higher or at least around 75 to 80%. In adult inside a hospital cardiac arrest, healthcare professionals should use either a 30 to 2 CV ratio or chest compression CPR with positive pressure ventilation at the rate of 10 per minute delivered without pausing compressions. That's a good practice statement. Next, please. This has been very well covered. I think I can skip that. This is AED placement for the first shock, the conventional anterolateral approach you can see on the left side picture, then the anteroposterior approach, in pediatric patients as well as in adult patients. In case of females, the pad or the paddle placement should avoid breast tissue. That's a good practice statement. And undergarment adjustment for positioning the pad should be done rather than removing the bra of the patient. It's always better to displace the bra as long as the pads, the defibrillator pads are in direct contact with the skin. It's okay. There's no need to remove the bra because that will take some time. Next, please. I think we can skip that. We can skip that also. This is, foreign body airway obstruction, 5 back slaps, which I've already covered, followed by 5 abdominal thrust. If it's an infant, 5 back slaps, followed by 5 chest thrusts. Start CPR if the victim becomes unresponsive. If fail to deliver 2 breaths, look inside the mouth, but blind finger sweep is not recommended. Next, please. Intra-arrest medication administration, intravenous of course, is the most preferred route if the IV line is in place. But in a patient who has cardiac arrest, the possibility of total venous collapse is very high, and you may not be able to find the veins which we normally can manage. In such patients, if there are 2 attempts at failing to locate the vein, it's recommended that the intraosseous access should be used. It's a reasonably good alternative. Endotracheal route is outdated and is now eliminated with the 2025 guidelines. No endotracheal administration of the drugs. Intraosseous is one in case you cannot look for the veins. Next one, please. This has already been very well covered by Dr. Rakesh, so I will skip this. Please go to the next one. Pediatric bradycardia, the older recommendation was that the patient should be given epinephrine plus minus atropine for bradycardia with poor perfusion. However, the current recommendation is that, since there is insufficient data to support a good practice statement for atropine, epinephrine, or transcutaneous pacing for hypoxia or post-ischemia related bradycardia, if there is a bradycardia with poor perfusion, unresponsive to oxygenation and ventilation, start CPR. So that is the current statement now. Rather than the drugs, if bradycardia and poor perfusion is there, start CPR. Next one. Intra-arrest blood pressure targets, diastolic blood pressure, as Dr. Rakesh also has mentioned, equal to or 25 millimeters mercury for infants less than 1 year, and diastolic blood pressure more than 30 or equal to 30 millimeters mercury for children in 1 to 18 years of age. Next one, please. Treatment of hyperkalemia, patients without cardiac arrest. For the treatment of hyperkalemia, it is suggested to use IV insulin in combination with glucose and or inhaled or intravenous beta-2 agonist. But now in patients with cardiac arrest, for the treatment of cardiac arrest suspected to be caused by acute hyperkalemia, it is suggested that IV insulin in combination with glucose be used. The inhaled or beta-2 agonists are now been withdrawn. Next one, please. Post-cardiac arrest care, active prevention of fever by targeting temperature less than. Can we go back, Dr. Rakesh, please? Yeah. By targeting a temperature of equal to or less than 37.5 degrees Celsius for patients who remain comatose after return of spontaneous circulation from cardiac arrest. It is suggested that there should be active prevention of fever for 36 to 72 hours in post-cardiac arrest patients who remain comatose. Titrating FiO2 for maintaining saturation, as Dr. Rakesh also had covered, that it should be maintained between 94 to 98%, and PaO2 60 to 105 millimeters of mercury in adult patients is recommended. And the target mean arterial pressure should be more than or equal to 65 millimeters of mercury. There is insufficient evidence to recommend a specific vasopressor to treat low blood pressure in patients with cardiac arrest. Next, please. That's the rescue position, which was earlier mentioned, that the patient's back should, in fact, the rescuer's knees should be at the level of the patient's back. If the rescuer is leaning by the side of the patient is on the floor, on the ground, or wherever, then of course there is no problem. The knees will be at the same level. But in case the patient is on a trolley, on a bed, or wherever or at a level higher than the ground, then the rescuer should ensure that the knee level should be at the level of the patient's back, so that there is effective compression of the chest, one, and there is no leaning, because if there is a leaning, there can be inadequate recoil of the chest because of the leaning itself. Next, please. We can skip that. It's just to show the level of the knees with respect to the patient's level who's lying on the ground. Summing up. With regard to recognition and initial response, call immediately for an unresponsive patient. There is no need to confirm abnormal breathing before activating emergency medical system. Assess breathing while waiting for the call to be answered. Assuming cardiac arrest, if there is any doubt about responsiveness or normal breathing, rescuers should assume cardiac arrest and start CPR immediately. That's an important change. Injury reassurance, a strong recommendation was issued to reassure lay rescuers that the risk of physical injury to a person who is not in cardiac arrest but receives chest compression is very low, approximately 0.7% for serious injury. Because sometimes the lay rescuers are scared that by doing the chest compression, they may not cause any harm to the patient. So it is just to reassure the lay rescuers that the possibility of harm is much, much less. Next, please. CPR modification techniques for obesity. Standard CPR technique is to be used 30 to 2 and there are no modifications required here. Head-up CPR is discouraged, it's discouraged, although this position sometimes was recommended to ensure that there is improved venous drainage, but it hasn't been seen to be of any leading to any improvement in the overall outcome of the patients. Removal of COVID-19 modifications, all modifications which are made at the time of COVID-19 have all been removed. Next, please. Use of AED access. There is a strong advice not to keep public access AEDs under lock and key, which sometimes is a trend. All public access AEDs should be accessible without any lock and key. However, if it is absolutely necessary, there should be very clear instructions to access the AED without delay. In women, repositioning of the bra rather than the removal ensure that is recommended, but ensure that the pads are on the bare skin. Anterolateral placement, one pad in the right clavicle and another in the left mid axillary line, lateral to the nipple. That's the position, and preferred standard for adult patient. Next, please. Dispatcher-assisted resuscitation recognition protocols. The dispatchers are encouraged to use standardized protocol, that is 2-question study, is a person conscious, and AC breathing normally, to identify the cardiac arrest quickly. Simplified pushing research indicates that simpler language, so for example, push as hard as you can, and video calls for feedback can significantly improve the bystander CPR quality. Next, please. Psychological support rescuers. This is for the first time that basic life support guidance recognizes that attempting resuscitation can be traumatic for lay rescuers, particularly in case they do not succeed in reviving the patient. Systems of care are encouraged to offer psychological support and follow up for those who intervene in this process. Thank you so much, Dr. Rakesh, for this additional trouble that you had for me, because somehow there was a software glitch and I couldn't really project my slides myself. Thank you so much once again.
Actually, it's a nice presentation. Actually, the cardiac arrest outside the hospital is about 70%, and it is more important for us in India because of the lack of emergency awakening of the emergency medical system and all those things. And definitely we have to place more emphasis on the CPR outside the hospital, because I told you there are 70% occurrence and most because of the lack of communications, lack of the structured procedure, because less than 2% of the people in India know CPR. They do not know how to communicate. They do not know how to go in a systematic manner. So, so all those things that are followed for the usual things like scene safety and all are normal, and the compressions and everything goes well. The only thing what you have mentioned is regarding the placement of the um, pads and the other things. So, anything, anybody wants to tell anything? I think another speaker is there. Meenakshi, another speaker is
There are
there.
no questions in the chat box.
Okay. No questions, sir. I think
No,
probably yes.
because it is advances, it is recent advances.
Not only that, many people.
Because only after reading this, the questions will come, and it is not practiced also. So actually, I have not expected any question, because if it is a regular case-based scenario, people will be asking with so many questions. Now it is recently it has come up. You only have opened up the dialogue. So probably the next week people may ask you what is what.
Okay.
So as there are no questions, the moderator can pass the concluding remarks so that we can wind up the session.
You pass the remarks.
If you want to say anything about ILCAR or IRCF, you can.
Actually, this IRCF started in 2017 with an intention to promote CPR in India. In 2015, when Abdul Kalam died giving a lecture in Shillong, IAM, then nobody has resuscitated him. In 2016, there was a study by one of the people published in Times of India that 98% of the Indians do not know CPR. So that was the thing actually stimulated the Indian Society of Anesthesiologists, and we felt that we should have our own guidelines, because when we are following the guidelines of others, we have to pay a lot of money, like about 8,000 for a BLS and 16,000 for ACLS. So I thought actually I was given the responsibility of bringing out our Indian guidelines in Indian scenario. I thought that the first thing is we have to reduce the training course price to a minimal and like just about 1,500 and 3,000 rupees. And then we started. We have all assembled in Hyderabad in 2017 April, and we have requested Dr. Rakesh Garg and other people to write the guidelines suitable to India. So they have come up with these guidelines, and there is a nice explanation what is Indian guidelines. So everybody thinks that Indian guidelines are what is Indian guidelines? Every human being is same, but the thing is the circumstances under which we are living are different. We do not have an emergency awakening system. We do not have a good ambulance system, and we do not have AED, and we do not have uh, a willingness to help others when a victim is on the ground. So in these circumstances, we have developed these guidelines, and now it is working out. We have reduced the cost of the trainings, and now we are establishing one by one in every medical college these training courses. And not only that, the government of India has come up with NETS, National Emergency Life Saving Procedures. That also they have also contributed to about 120 medical colleges to uh, establish the training centers. And the most important thing here is actually the knowledge. We have different languages, different religions. We have a lot of superstitions, and we are amenable to fallacies and reading a lot on the WhatsApp and knowing. And some of our people, even our seniors and professors, they think that whatever they know is correct and they don't read or don't update themselves. So those are the things. Even then, even some people they believe that intracardiac adrenaline is good. Even some people they believe that cardiac thumb is also good, and they sometimes argue. But we have to tell them the most important thing in the cardiac arrest is to immediately initiate the chest compression, because we have to save the brain from the lack of oxygenation, and that is the important. Even if there is, don't bother about seeing the pulse and all. Don't bother about that. Even if there is a feeble pulse, you start, and even it is there in the new guidelines. And don't bother about this whether the ribs will be broken or something. These are the most usually asked questions. Don't bother about let the patient survive first. Ribs will be healed later. And not only that, it may not be a cardiac arrest, it may be a syncope or something like that. Whatever it is, don't waste time. But if the victim is not reacting, just start chest compression. Definitely he will recover. That is the important thing, and we do not want to lose time. It is clearly told that even 1 minute delay uh, decreases the chances of survival by 7 to 10%. So we should not. And many people are thinking it is a golden hour. There is nothing like golden hour in CPR. It is only the minutes, and we always think of a fraction of a minute, like 10 seconds. And if there is, and you don't remove the hand from the chest, and if something like keeping a analyzing system, analyzing time and all, when you keep out, immediately it is only 7 seconds that can be allowed to stop the compression. So this is the most important thing is, and it is not everybody will be thinking about the heart. Of course, it is the heart that pumps the blood, but it is the brain that governs everything, and we have to oxygenate the brain more effectively. That in that way it will be we can be saved. And regarding these things like hypothermia and all, of course, hypothermia may be good, but it is not. It need not be decreased to that much. If it is 36 or 35, it will be all right, and it cannot be practiced in every center. This because of the complicated nature. And ECMO and all people are coming up with, but when it is there, there will be some uh, advanced centers. There it can be done and it is useful. And even when to stop the CPR. It is the question that is being raised nowadays. And when you are connected to ECMO, connected to ETCO2, definitely you can tell. And another thing, some people said that about 45 minutes and all. It is not 45 minutes as long as you are compressing the chest, as long as you can feel the carotid pulse. It means the blood is going to the uh, brain, and you can go on doing the CPR. In Indian guidelines also, we are not specified the time, but you have to observe. And regarding the, of course, the CPR in other circumstances, Dr. Rakesh has clearly shown, has talked. And regarding the CPR in pregnancy, actually, we were advising to keep a wedge on the right side. Now it is clearly said it need not be a wedge. You push the uterus to the left side so that the aortocaval compression can be decreased. So these are all some of the things. And as we practice in India, there are many types of people and a lot of superstitions and fallacies will be practiced more. If somebody says that you practice cough during the CPR, and during cardiac arrest, there is no problem. But what is the when the victim is unconscious, there is no question of coughing, and even if he is conscious, the cough will not increase that much of intrathoracic pressure to compress the right ventricle. So these are the things, and anything can be added.
Sir, Dr. Rakesh has raised his hand.
No,
Please,
just one thing that you please go through those ILCOR updates. This is important for the postgraduate students. You may be asked a question. So there is a complete publication of the ILCOR updates, which has nicely mentioned what those changes were and about the management plan also. So they are available on the freely available, downloadable on the slides, and nicely describe all the changes with justification. And this will be good for postgraduate students, sir. Over to you, sir.
Thank you. I think the moderator has given the final conclusion, but I want to say only one thing regarding the rib fractures. Sir has mentioned about even if the rib is fractured, let it heal later. But when I was house surgeon, I was informed by the then physicians that if there is no rib fracture, that means you have not given the correct cardiac massage. That was the thing they said. But now I want to say, youngsters, definitely the scenario has changed. If you are compressing the sternum, definitely there will not be any rib fracture. It cannot be. If you go right or left, then only the rib fracture will occur. And please don't ever think that if there is a rib fracture, let it heal later. It can be accidentally happen, but intentionally we should not do, because sometimes the fracture rib will injure the lung, and resuscitation time it will produce another sequelae. So if you are compressing the sternum, definitely there will not be any fracture of ribs. So never ever think of fracture ribs. This is just like when you are doing a hysterectomy. If you look for ureter, then ureter will be injured. You have to do it just like that. Same way you compress. If you are very conscious about rib fracture, definitely that is going to happen. So I thank Dr. Abinaya, the youngest faculty today, with the senior most faculties, the trio, Dr. Rakesh Garg from New Delhi, Dr. Baljit Singh from New Delhi, and Dr. Chakra Rao from Kakinada. Moreover, Sar has recently has become the director of the Cosmopolitan Club. That is one more addition for him. So it is endless. It is endless. His achievements are endless. So now our swastika is restless. So swastika, you can go for concluding remarks and close the session.
Thank you so much, sir. So thank you so much to all the dignitaries present here, and I hope you had a seamless experience, sir. So with everyone's permission, we are concluding the session in here for today and hoping to have you again very soon. Thank you so much, sir.
Thank you.
Thank you.
Thank
Thank
you.
you. Good night.
Really.
You.